resident at Shelby Hospital. Now, I have divided this pesticide poisoning into two parts. The first part consists of organophosphorus poisoning, and the second part consists of these herbicides, rodenticides, and aluminum phosphate poisoning. Organophosphorus and carbamate and pyrethroids in the first part. Coming to the pesticide types, there are insecticides and repellents. Insecticides are organophosphates, carbamates, organochlorines, pyrethroids, pyrethrin, neonicotinoids, neristoxin analogs, repellents like amitraz, DEET. There are often multiple formulations. They produce complex toxidromes. And coming to the most famous organophosphorus poisoning, and this is the most common poisoning, and in exposure by inhalation, mucous membrane, transdermal, transconjunctival GN exposure. And generally, organophosphorus affects the acetylcholinesterase. Acetylcholinesterase is of two types: the true or red cell cholinesterase. The second type is plasma or pseudo or butyryl cholinesterase. True or red cell cholinesterase is found in RBC, nervous tissue, skeletal muscles, whereas this plasma or pseudo cholinesterase is found in the serum, liver, pancreas, heart, and the brain. And the main mechanism of action of this organophosphorus compound is they inhibit the cholinesterase. Generally, after the nerve stimulation has completed, the acetylcholine will be degraded by this cholinesterase. So, because this cholinesterase is inhibited by these organophosphorus compounds, the acetylcholine will not be degraded. So, it will lead to overstimulation of the acetylcholine receptors that will cause cholinergic crisis, and that will cause central peripheral clinical toxidromes. Organophosphorus compound, they bind irreversibly to the cholinesterase, and they inhibit the enzyme by phosphorylation. And this binding of the organophosphorus compound to the enzyme irreversible is called aging. Aging means it is permanently damaging the enzyme. So we give antidotes in organophosphorus compound, but those will be effective only before the aging occurs. Before the aging occurs, only these antidotes will be effective. And the clinical features, if you see based on the onset of occurrence of symptoms, so we can see acute poisoning, intermediate syndrome, chronic toxicity, and organophosphate induced delayed neuropathy. Acute poisoning, the symptoms will be within 8 to 24 hours, and the symptoms onset will be rapid with inhalation and least with transfer. In severe poisoning, we have the nicotinic features coming first. And the clinical features can be divided as muscarinic effects, nicotinic effects, and CNS effects. So the muscarinic effect, we have the famous mnemonic, sludge dumbbells. Sludge consists of salivation, lacrimation, urination, defecation, GI pen, and emesis. The dumbbells consist of the defecation, urination, meiosis, bradycardia, bronchoria, bronchospasm, emesis, lacrimation, and salivation. So the bees are the killer bees, that is the bradycardia, bronchospasm, and bronchoria. Coming on to the nicotinic features of organophosphorus compounds, these are muscle fasciculations, cramps, weakness of muscles, even the diaphragm muscles. So these respiratory muscle weakness will cause ventilator failure, mydriasis, pallor, tachycardia, hypertension, areflexia. And CNS effects like anxiety, restlessness, emotional liability, tremors, headache, dizziness, confusion, delirium, hallucinations, seizures, coma. So these are the effects. And this is a pictorial description of organophosphate poisoning, showing the muscarinic and nicotinic effects. And coming on to the intermediate syndrome. The intermediate syndrome occurs within 1 to 5 days. And the clinical features includes paralysis of the neck flexors, muscles innervated by the cranial nerves, proximal limb muscles, respiratory muscles. Symptoms, signs of cholinergic excess, they are absent here, which are present in the acute poison. And it requires aggressive early antidote therapy before the aging occurs. Chronic toxicity consists of sensoromotor axonopathy, and it's seen in agricultural workers. And they have symptoms like leg cramps that will progress into weakness and paralysis. And this will mimic the Guillain-Barré syndrome. Organophosphate induced delayed neuropathy that consists of cognitive dysfunction, impaired memory, mood changes, autonomic dysfunction, peripheral neuropathy, and extrapyramidal signs. How do we diagnose that there is organophosphorus poisoning? Based on history, based on suggestive toxicity, and laboratory cholinesterase assays. And generally, the patient of organophosphorus poisoning have a hydrocarbon or garlic-like odor. And the majority of the patients have altered mental status, pinpoint pupils, excessive sweating, and breathing difficulties. And normally the routine lab work do not lead us to the diagnosis of organophosphorus poisoning, but only with the history and with the symptoms we can predict that the patient has consumed some organophosphorus compound. And even in ECG, we find some features like prolonged QT interval, Torsade D point is VT or VF, AV blocks, STT changes, and peaked T waves. And generally, we have the, as we have discussed earlier, plasma butyrylcholinesterase and red cell acetylcholinesterase. The plasma butyrylcholinesterase is easier to detect, whereas the red cell acetylcholinesterase is the most accurate. And it is decreased by 50% in asymptomatic patients post-exposure. And that is decreased to 10 to 20% of normal activity in moderate poisoning and decreased to less than 10% in severe poisoning. But in both of them, the plasma butyrylcholinesterase will decrease first. And as we have told that aging occurs, due to that, for the new enzyme to produce, it takes 28 to 42 days. And the plasma butyrylcholinesterase also decreases in chronic disease conditions like liver diseases, infections, pregnancy, hypersensitive reactions, low albumin, drugs, malignancy, and malnutrition. And red cell acetylcholinesterase decrease in hemoglobinopathies, pernicious anemia, concurrent malarial treatments, oxalate containing blood containers. And the treatment of the organophosphorus compounds, generally it consists of decontamination, atropine, oximes, and the symptomatic treatment. Generally, gastric lavage and activated charcoal has no role in organophosphorus compound poisoning. And decontamination consists of removing the cloth and giving protective clothing to the healthcare workers and wash the patient with soap and water and handle and dispose water runoff. So whatever the water we have used, dispose it. And atropine, generally we have to give in a dose of 1 to 3 milligram IV bolus. In children, we can do 0.05 milligram per kg. We can double the dose every 5 minutes. This is called atropinization. What is atropinization? It means that the response that we get by doubling the dose of atropine, that is clear chest and auscultation, heart rate more than 80 per minute, systolic blood pressure more than 80 millimeter of mercury. This is the, and we can even start an infusion of 0.4 to 4 milligram per hour IV. And we can avoid atropine toxicity. That is also needed. We can't give excessive dose of atropine. And consists of oximes, raledoxime is used, which should be given as soon as possible. And the stat dose is 30 milligram per kg IV in adults, and in children also 30 milligram per kg IV, but not more than 1 gram. Infusion we can start at 8 milligram per kg per hour for 24 to 48 hours. And seizures, if at all the patient have seizures, then we can give benzodiazepines. Then this is the picture showing the acetylcholine esterase. And there is a difference between organophosphorus and carbamates that we will discuss. So here the acetylcholine esterase has an esteric site and an anionic site. The organophosphate compound will bind at the esteric site. And whatever the oximes we are giving, they bind at the anionic site. So that is why oximes before the aging can be used as an antidote in organophosphorus poisoning. But whereas if you see the carbamates, they bind at both the esteric and anionic site. So due to that, the oximes cannot act in carbamate poisoning. So they are ineffective. So that is the difference. And the organophosphorus compound, they bind irreversibly, whereas the carbamate poisons, they bind to the acetylcholine esterase reversibly. The bond is temporary. So coming to carbamates. So they are exposed by dermal, gastrointestinal and inhalational route and transcend a reversible bond between cholinesterase and carbamates. So and dissociate within minutes to hours. Aging doesn't occur as well as we have discussed earlier. And a new enzyme restoration is not required. And similar to cholinergic toxidrome, as we have discussed earlier, short duration of action, less CNS toxicity and seizures doesn't occur. And children can have even CNS depressions. And diagnosis generally enzyme activity returned by 4 to 8 hours. So then we can predict this. We have the patient has taken carbamate poisoning because the enzyme activity doesn't return it as soon as this in case of organophosphorus poisoning. Then atropine is the antidote of choice. Coming to organochlorines. So organochlorines we have to exposure through inhalation, GI or dermal. So pathophysiology is the central neurological stimulants is the thing happens to GABA, the inhibited neurotransmitter is inhibited. So hyperexcitability of the neurons will happen and organochlorines are highly lipid soluble. So the rate of absorption will be also very high because all the lipid soluble whatever drugs or whatever the compounds are absorbed at a faster rate. And the clinical features we can divide into mild and severe. Mild consists of dizziness, headache, fatigue, malaise, delirium, tremors, and myoclonus. In severe, we have seizures, hypothermia, coma, renal injury, even death. And treatment consists of decontamination. And if at all patient have seizures, then we can use benzodiazepines. But if the patient have dysarrhythmias, so never use epinephrine because epinephrine in association with organochlorines, it can sensitize the myocardium to endogenous catecholamines that will worsen. So that's why avoid epinephrine in case of organochlorines. And activated charcoal can be used and gastric lavage can be given. Coming to pyrethroids. So pyrethroids and pyrethrin. So pathophysiology, dermal inhalation and ingestion is the route of exposure. They block the sodium channel at the neuronal cell membrane and a repetitive nerve discharge happens due to this. And even they inhibit GABA receptors, that is also further increasing the repetitive nerve discharge. And that will increase the nicotinic cholinergic transmission also. Norepinephrine release will also be increased. Sodium calcium exchange will be inhibited across the cell membrane. And clinical features of these pyrethroids is basically allergic hypersensitivity reactions. That includes dermatitis, bronchospasm, rhinitis, anaphylaxis, hypersensitivity pneumonitis. And systemic toxicity is also caused by these pyrethroids that will lead to pulmonary edema, respiratory failure, and even seizures. The treatment consists of supportive care and the treatment of the allergic manifestations. And coming to neonicotinoids, so similar to nicotine, mild to moderate poisoning, nausea, emesis, diarrhea, and headache, and severe poisoning, respiratory failure, rhabdomyolysis, encephalopathy, hypotension, and renal failure. And the treatment consists of support. And nerestoxin analogs, these are very mild or low toxic compounds. So the pathophysiology is influx of the extracellular calcium, and even they will cause release of the intracellular calcium from sarcoplasmic reticulum. That will cause, through the skin exposure, it will cause nausea, vomiting, muscle tremors, dyspnea, mydriasis. And case of ingestion, decreased level of consciousness, muscle fasciculation, spasms, seizures, hypotension, and hypoxia, and death. So supportive treatment is the thing. And the compound amitraz, it is an insect repellent. So that will act as agonist for the postsynaptic alpha-2 receptors. So it will inhibit MAO, it will inhibit prostaglandin synthesis, and the clinical features include depression, bradycardia, respiratory depression, meiosis, hypothermia, hypotension. Supportive therapy is the thing. And for DEET, diethyl 3-methyl benzamide, it is also insect repellent. Ingestion, skin exposure, the roots, and it will cause systemic toxicity. That will cause restlessness, confusion, insomnia, altered behavior, slurred speech, ataxia, tremors, muscle cramps, hypertonia, seizures. And symptomatically, for seizures, benzodiazepines, skin decontamination, if at all it is a recent ingestion, for DEET, we can use activated charcoal. So until now, we have discussed that for carbamates and organophosphorus poisons, we cannot use this gastric lavage and this activated charcoal. So until now, we can use for pyrethroids, we can use for neurotoxin analogs, we can use for neonicotinoids. Okay, so organochlorines also we can use. So for only carbamates and organophosphorus compounds, we cannot use this activated charcoal and this gastric lavage. So this is the end of the first part. The second part we will discuss in the next session. Okay, thank you very much.